like to express my pleasure for those that they come today from all the very distinguished electrophysiologists that they come from all over the Greece. And I would like to welcome everybody who came here. It's a great pleasure for me. And of course, it's a great pleasure for me to introduce a really distinguished electrophysiologist, Karsten Neven, from Essen, Germany, who is very well known to everybody, one of the most respected electrophysiologists in Europe, and someone who is specialized in complex arrhythmias, using with great skill cutting-edge technology. And for this reason, today he will talk. He will give us a speech about PFA, a comparison of systems. Kars, it's a really pleasure for me to be here again. And before starting, I would like also to express my gratitude to Boston company who sponsored this talk. But generally, I would like to express my gratitude because it always stands next to us, giving all those resources that we needed to improve our skills and our ability to tackle especially complex tachycardias. Karst, you can start. Thank you very much again.
Kalimera. Thank you very much for the kind introduction and for the invitation. It's really a pleasure to be here in Thessaloniki. Thank you very much. My name is Karsten Neven from Essen in Germany, and I will speak today about pulse field ablation, a comparison of systems. Of course, there are now many systems on the market by now in Europe. I cannot talk about all the systems because this would take more than 1 hour, but I will take the most important ones, or the ones where the most experience is gained now. So these are my disclosures. Of course, we know from the new European guidelines published last year in August that catheter ablation is, of course, now more in the forefront. We know for paroxysmal atrial fibrillation is now a class 1A recommendation, and for persistent atrial fibrillation it is a 2B indication, but especially for paroxysmal atrial fibrillation and for patients with structural heart disease, catheter ablation is going to be more of an option. And since 2021, there is the CE mark of the first PFA system in Europe, and we started our program with PFA 3 months later, so in April 2021. So we have a lot of experience by now. And as you all know, the very first randomized controlled trial was the ADVENT trial comparing cryoablation and RF ablation versus pulse field ablation. And here you see the 1-year results where it was non-inferior, but you should not forget that thermal ablation had already more than 20 years of development and experience. So that means that the operators were very experienced, and also the products were already developed for a long time, versus pulse field ablation, which was still the first generation of catheters. And in this trial, the physicians had no experience using PFA. So that is, of course, a big difference in the use of the technology. And a few weeks ago, this paper was published by Tobias Reichlin from Switzerland, and they also compared pulse field ablation to cryoablation. So you think it might be the same study, but here the difference was that the operators who used PFA had to have more than 6 months of experience using the PFA system, and of course they should have experience in cryo. And now you see, with the experience in the PFA ablation, the efficacy now was slightly positive for pulse field ablation. So you see that also the experience in using the PFA system makes a difference in the efficacy. So of course we can only hope that when the PFA systems will have more development, that these lines will even more divide. This was published last year, the 17 case study from the Manifest cohort, where we also looked at the complications, and you know that there are very, very few PFA-specific complications, but there was a new one. There was hemolysis and renal failure. That was a surprise to everybody. So, of course, we looked into these patients, and that were 5 patients in this cohort. And what you immediately see is the number of PFA applications that was with this system way too high, because the normal number of applications used with the system is about 32 to 40, and here you can see that they use 4 to 5 times as many applications as was recommended. And to me, it is not a surprise that certain complications will happen. So I want to immediately say a word of caution. With any system you use, don't overdo it, even when it looks very easy or it feels very easy to give extra applications. Please always be aware that there is a nominal number. And when you look in the case of Farapulse, then there was a very steep use worldwide. So you can see that the first in man was 2017. The first publication was at HRS in 2018. The CE mark was in 2021. We were the first to start here. And now you see how rapidly the market adoption has been with the clinical trials. And at current, over 250,000 patients have been treated globally, which I think in 4 years' time is quite a revolution. And this has changed our workflow. And if you look at the impact on the workflow, then I have here 2 diagrams from hospitals in Prague, from Josef Kautzner and from Peter Neusiel, which are big hospitals. And then you see that historically they have been using RF mainly for PVI, a little bit of cryo, but since 2021 you see that PFA has totally suppressed RF. So RF is almost completely gone, yeah, and PFA has taken over this market for primary PFA. So you might say, okay, there's only one hospital, but then you go to the next hospital, exactly the same story. They have been using RF for a long time as the major therapy choice for PVI, and you see since 2021 PFA has almost taken over everything for primary PVI, and in our hospital it is exactly the same. So this is what you see in many hospitals. And of course, at the moment we still make selective PV angiographies. I think it's really important to have a real-time visualization of the anatomy, and you can even use it to guide the catheter. But this is still a 3D based, a fluoroscopy system based approach, and this is not yet a fully 3D based approach. And of course, this means that we have to use fluoroscopy. And this is a table from the ADVENT trial, where you see that for thermal ablation, so RF and cryo, they used 40 minutes of fluoroscopy, and in PFA, they used 21 minutes of fluoroscopy. Of course, don't forget that these operators were still naive. They had no experience in the use of PFA, but you can surely imagine that if you only use fluoroscopy, then you will have to use fluoroscopy for a longer time, which is maybe not what we want. Some operators, they go on LinkedIn and they publish and they say, I can do the procedure with only 1.5 minutes of fluoroscopy. But in my understanding, then you're not looking correctly or meticulously at the catheter position. I think you really need some fluoroscopy to actually know exactly how the catheter is being positioned in the vein. And here you see an example where if you use fluoroscopy and angio, then you can nicely see where you are. But this is, of course, not the way that we want to go forward. And also the companies realize that, and all the companies are building their own 3D-based systems. And this is from Boston Scientific, the next generation catheter, the FARAWAVE NAV catheter. This is a navigation-enabled catheter where they have a navigation sensor with a proximal shaft electrode, and they can use this now in the 3D mapping system. And we were one of the first in Europe to do this, and this was a few months ago. So this is a new technique, and we also have limited experience with it. I know in Greece you also have, I think, 3 or 4 hospitals that are using it now. And what you can do with the FARAWAVE catheter, you can make a map with the catheter. You can make a normal map without any information. You can make a bipolar map. You can make a sort of an activation map also. It is not perfectly made for that, the catheter, but you can do it. And once you finish the map, then you can also ablate with it, and you can actually predict where the lesion is going to be in white. And after ablation, you see that the white lesion tag now turns orange. That means you have created some lesion, but it's not the good lesion yet. And after the second ablation, you will see that the orange tag now turns red. And the red tag means this site has been ablated enough. So it gives you a feeling for did I position my lesion tag correctly or not. And I think one of the most interesting things about this system is that when you align the view so that you can look really through the axis of the vein, then you can nicely see the position of the catheter in the vein. So you know immediately, are you too anterior, are you too posterior, and are you nicely coaxially aligned? And I think this is really important. And once you've finished one side, you go to the next side, of course. You also rotate so that you can nicely see through the axis of the vein, and then you can do the ablations. And even when you want to do extra PV ablation like the posterior wall, that is now of course quite easy because you have all the information on the anatomy at hand. There's not so much data on the FARAVIEW system yet. There was a small study, 3 European centers, 30 patients only, that was conducted last year. And this was a poster that was presented at the AF Symposium in Boston in January, where they compared the lesion tags to the post map using an Orion catheter. So they did Orion catheter after ablation, and then they compared that to the lesion tags, and they overlaid them, and then they looked how accurate are the lesion tags compared to the actual bipolar map. And this was presented here. So you see that there was a difference only of less than 1 millimeter between the projected lesion tags and the actual map with Orion catheter. So that means that if you make the map carefully, the lesion tags will accurately predict where the lesion is going to be. Of course, then the question is, do we need to map, right? This is a small study from a few years ago from Switzerland, where they investigated 200 patients. In 130 patients, they did a map. This was still with Carto mapping. And in 70 patients, they did no mapping. They compared the 2 patient groups, and there was no difference in outcome after 1 year. But of course, this is a single center study. This is a small study, so maybe the results are not very strong. Now there is a second study. It's a prospective Italian registry in 17 centers where they collected data of 1,800 patients. And here they also compared mapping versus non-mapping. And what they found is that in PVI only, for paroxysmal and for persistent atrial fibrillation, there's no difference in outcome. So whether you map or not, there's no difference in outcome. Also, when you do PVI plus additional lesions in paroxysmal atrial fibrillation, there's no difference in outcome. Only when you do PVI plus additional lesions in persistent atrial fibrillation, then mapping shows a better efficacy after 1 year. So that means we still have to look where does mapping have its place using a single shot catheter for PVI. I've been talking, of course, mainly about the Pentaspline catheter. There are more catheters on the market. I will discuss these catheters with you. So lattice tip catheter, variable loop catheter, and also single tip PFA. This is the variable loop catheter. So you can see it looks like a lasso catheter. You can change the diameter of the size by turning this knob. So you can make it bigger and smaller to adjust for the size of the pulmonary vein. And the nice thing about this system is that it's fully 3D integrated in the system, and you can map with it, you can ablate with it, so you can see the lesion tags, and of course you can immediately remap with it. And these electrodes are quite small, so the mapping density, I think, is quite okay. The disadvantage of this system is that the loop is quite stiff, and it doesn't really nicely adapt, in my experience, to the anatomy of the vein, especially when the vein is narrow. So when the vein is not round but is oval, then it's very difficult to position the catheter correctly, because this system is not over the wire. From Medtronic, there's also an over-the-wire system, the Pulse Select system. This is a little bit more stable into the ostium of the pulmonary vein, but that system is not 3D integrated yet. Of course, you can use it with a NAVIC system, for example, but the system itself is not fully 3D integrated. A different approach is this approach. It's the Galaxy generator from CardioFocus now. So this was first galvanized, now it's CardioFocus, and this is only a standalone PFA generator. So you don't buy the whole EP system. You only rent this PFA generator. And the nice thing is you can use this PFA generator with any available contact force enabled catheter. So for example, we use this with the Bison Webster Smart Touch catheter, but you can also use it with the Tacticat catheter or with the Boston catheter. And the nice thing is that now you can do your old school point-by-point PVI if you want to. So you can make a 3D map with any mapping catheter, and then you can do the point-by-point lesions like you're used to do that. But the nicest thing is that you can also make tailored linear lesions. So if you say, I have an atrial flutter, I have an atypical flutter, or I have a redo, then it's very nice because you can really nicely make linear lesions. We conducted the first randomized trial comparing this system versus Farapulse, and I must say the results of this system are really, really good. And the nice thing is that your footprint, your lesions, are small enough to be precise. And I think this is opposite to single shot catheters, where of course when you make lesions on the mitral isthmus, on the cavity-cuspid isthmus, the lesions are going to be really big. And with this, we know the size of the lesions, so this is really nice. And there's one small study now published a few months ago, the Eclipse AF study by Ante Anish, and they compared, so they looked at the 1 year data, and what they found is that they remapped patients after 90 days, and what they found is that there was a sort of an optimization needed. So they had also some pulse parameters that they changed. So there was a learning curve also in the technique, and then they also looked at the different catheters. So the Tacticat catheter from Abbott, the StablePoint catheter from Boston, and the Thermocool catheter, and they found that on a PV basis there was quite a high acute success rate in the PVI. So that means that this catheter is very much able to isolate the veins nicely, and it was quite a small study, but you see that the efficacy after 1 year was quite high. I think 90 is a little bit much, but you see that paroxysmal and persistent atrial fibrillation had quite an acceptable freedom of arrhythmia rate. A totally different and also new design is the lattice tip catheter. So this is the Avera system from Medtronic, where you see that they have a novel catheter. It's 9 millimeters big. It is a lattice tip catheter, so that means it is a little bit, it's like a mesh catheter. And the nice thing about this system is it is 3D integrated with its own system. So you have to buy another system, and then you can map with it. It has mini electrodes on it, so you can see that on the catheter itself there are mini electrodes there, and you can also visualize them here in the middle, so you can make a high definition map with it. And then you can use the same catheter to ablate, and this catheter is able to ablate with PFA and with RF. This system was originally built to perform only RF ablation, but then PFA came on the market, and the company quickly changed also their workflow, and they added a PFA generator to it. So now you can use PFA and RF. In Europe, the experience is quite limited at the moment because of the availability of the catheters. But here also the nice thing is that you can do PVI, of course, but you can also ablate linear lesions, and you can choose if you want to deliver PFA in green, or for example anterior line here with RF in red. So you can toggle between RF and PFA as you wish. And here you see the catheter again. It's a mesh catheter, and you see the mini electrodes on it. So this is quite a high definition map. So in conclusion, ladies and gentlemen, PVI using FARAPULSE is still a fluoroscopic procedure. The first randomized controlled trials show that first generation PFA for PVI is as good as 20 years of development of thermal ablation. Of course, we need a reduction in fluoroscopy time, and we have to have 3D mapping. I think this is going to be necessary for the future, and I hope I've shown you that a lot of new developments are on their way, and every company is already building their next generation catheters. So I think the next few years are going to be very, very exciting still. Thank you very much.
Karst, thank you very much for this very nice overview of different systems that we use or we are going to use in AF ablation or even in some other complex tachycardias. We have here, as I said before, many distinguished electrophysiologists from all over the Greece. So we can take some questions. Is there any question?
So I know that some people also use FARAVIEW now here in the room, and I think for everybody it is still new. So of course I would be very interested to hear about the experience, the difference between FARAPULSE and FARAVIEW. So if somebody has experience with that, then I would also like to know their experience with it. So if somebody has
there are some persons here that they have some experience as the president of our working group electrophysiology, Dr. Andrikopoulos. So Yorgos,
so thanks for the
tell us your experience.
Yeah. And thanks, Karst, for being here. You see, it was the first PFA procedure I watched in Karst's lab. So it's always nice to see Karst. Karst, I have the impression that FARAVIEW is a perfect tool for navigating and a modest tool for mapping. But regarding radiation, and we've seen data published by Gupta and others pointing the increased time of fluoroscopy. Well, I have to admit that during the first 20 cases, there was a tendency for increased time. But for the last 30 cases, I have managed to see always below 10 minutes, and apart from transeptal time, because we keep tracking fluoroscopy time, it's always 5 to 8 minutes of fluoroscopy if we omit extensive mapping and we concentrate on the antrum. So what do you think? Is there any reason for mapping the atria when we use FARAVIEW for cases of PVI only, or we still have, like we do in my lab, we map only the antrum in order to optimize lesion set, and doing that we also decrease significantly fluoroscopy time?
Yes, I think that's a very good question. We are still learning how to perform the procedure, right? So I think nobody in Europe has a great experience yet. In America, they use it a longer time. And when I go back to my slides, I think there's one very big advantage of the system. So we don't map the whole atrium ourselves. So what we do is we first go to the left side, and we map the superior and the inferior vein, because I want to see the ipsilateral anatomy. I don't want to see only one vein, because I think you need more information, especially to see where is the carina. So we map the whole left side, but we don't map the posterior wall. And then we ablate the left side, and then we remap the left side. So we stay on the left side first, do everything there, and then we go to the right side.
Why do you remap the left side after giving the lesions?
Because now I can. Because now I can. Of course, the remapping is not ideal, because the catheter is not a mapping catheter yet. It is coming. So the next generation catheter, which is coming soon, will have all 20 electrodes as a phase sense electrode. So now you only have the third electrode on each spline, right? But this will change, so we will have more of a high definition mapping. So that's number one. Number two, I think if you have the opportunity to do a little map, then that's best for the patient. So we map first this part, and then we go to, sorry, I'm wrong. Sorry, we go first to the left part, that's this part, sorry, and then we go to the right, and then we do the right part. Yeah, but I don't map the posterior wall if I don't ablate there.
A final question, if I may, to Kars. What I found really exciting with the software is the reliability of the field tagging software.
Yes.
Because, the cases I have done high density mapping using Orion, because for high density mapping you can't use this catheter. Mm-hmm. I was amazed by the fact that what this tagging field software shows to us, it's the area of true irreversible electroporation that we provide with this catheter. It was exactly what we got with ultra high density mapping with Orion. Is this your experience as well?
Yes. So we did not compare ourselves, but there is this small study I just presented that was presented in January and at the Boston AF, where they analyzed 9 patients. So this is a small cohort, yes, and they performed a post-map with Orion, and then they compared this to the field tags, and they saw a difference of less than 1 millimeter between the border zone of the low voltage, high voltage in Orion and the field tag. So the field tag accurately predicts, but of course it is dependent on how precise the mapping is. Because in my experience, if you make the map, you should not push too much with this catheter, because it is quite a stiff catheter system, and if you push, then you will display the tissue too much, and you will sort of inflate the left atrium. So I think during the mapping, you should be careful not to push too much, because then the anatomy is not real.
Any other question? Kars, may I ask you something? When we do a PFA, we follow some sort of certain movement. I would say sometimes, like a monkey, we do the same thing always. As you recommend, anterior wall, posterior wall, all this stuff. Now that you had the opportunity to use FARAVIEW, and you can see the position where you would ablate anyway, did you change your movement? Did you change your approach? That doesn't really make any difference compared to what you did before and now. And the other question is that usually we are really surprised and excited because we cannot see any signal. Mm-hmm. But using FARAVIEW now in those veins that we really extinguished everything. Did we really manage to make a complete isolation? Or yes. What's your experience?
Yeah. So I think it depends a little bit on how you used to work with the fluoroscopy system. So if you are, I think, very precise, you make a good angio, you look in contralateral views, then maybe the advantage is not so big. I want to show one slide again. Let me see, it's the other way, it's like that. So we need to have angio, that's for sure. So fluoroscopy, that's for sure. And again, if somebody tells me I can do a fluoroscopy-based Farapulse ablation with only 1.5 minutes of fluoroscopy for everything, for transectal puncture, then I know he's not looking. You can't be precise in your positioning without ICE, without TEE, and you use only 1.5 minutes. To me, that means you are not looking. Very simple. And I think what is really great about this system is that it gives you real-time information about the coaxiality of the catheter in the vein. So it shows you the position of the catheter in the vein. And I think for operators who maybe have not a perfect workflow, whatever it is, they can now sort of auto-correct themselves because now they see what they're doing. So I think it is an add-on tool to guide you in the precise positioning of the catheter, because I think the positioning of the catheter is super important. Because once you're in a good position, then the energy takes over and does the rest. We don't have to worry too much about gaps then. But I think the good positioning can be improved by 3D mapping.
Is any particular vein that you think that FARAVIEW would make any difference in complete isolation?
Yeah, sometimes you have. So of course, I think the most difficult vein is the right superior pulmonary vein because it is the biggest and the catheter stability is not always the best there. So especially during ablation and when you have phrenic nerve capture, you will have some dislodgement of the pedal. So for me, that makes a difference to see exactly where I am, and I want to make sure that I have a good overlap over the carina. That's number 2. For the remapping, it's of course a little bit difficult, especially in the left superior pulmonary vein, because we still see some signals, far field signals from the left atrial appendage, especially because the interelectrode distance of this system is still big, because the system takes the electrodes, takes the EGM from the 3rd electrode on one spline to the 3rd electrode on the next spline. So that means the interelectrode distance is still quite big. And that means you see a lot of far field. So in the left superior pulmonary vein, you will often see during the remapping still some EGMs, and then you have to do differential pacing to make sure that you have an LAA signal and not a local potential. I think this is very important.
Is there any other question from the floor? Yeah, Professor Doniadis.
Congratulations, that was very informative. 2 things that come in mind. We struggle every day to be effective yet practical in terms of the turnaround of the patients. So I was wondering, in your center, what's your workflow? Do you suggest that these cases can be accomplished as day cases and patients get discharged on the same day? Or do you routinely keep the patient overnight to monitor renal function? That's the first question. Mm-hmm. And the second one is that what comes in mind is that we all have always envisioned the era that all the tools would be available and we would map and ablate with different energy sources. So this looks like it's coming, and that's encouraging. But if you had the opportunity to map in a complex case, in a redo case, and you had RF and PFA available, on what basis would you make your decision which energy source to use?
Yes, well, thank you for the questions. Those are very good questions. So the question number 1, daycare ablation. In Germany, for financial reasons, we cannot send the patients home the same day. So that's very simple. We just cannot do it because there's no reimbursement for that. If you go to different countries, to the Netherlands, for example, if you go to America, same-day discharge is common. Everybody goes home, or not everybody, but the majority goes home the same day. So they typically use a vascular closure system. They observe the patients for 4 to 6 hours, send them home the same day, and then typically a nurse calls them the next day. How are you doing? How's your groin doing? How do you feel? Of course, there are some complications. This has been described by Jason Andrade with cryo very nicely for the first time. But in general, it is quite acceptable. But they typically use vascular closure systems like ProGlide. That's number 1. So, and I know in Germany, in 2026, so next year, the DRG system will change, and same-day discharge will also be possible for PVI. So we will have to go there anyway. We are not used to that, and also the patients are not used to that, but we somehow have to get there. That's number 1. Number 2, the renal function. So yes, it is a big discussion now in the literature, and especially in America, they are now very, very worried. And if you submit a paper, the reviewer always asks you now about hemolysis because it's a very big thing. I think it is not a big thing if you stick to the recipe. So if you don't overdo it. Now for this system, for the FARAPULSE system, the consensus is if you don't ablate if you don't apply more than 60 to 70 applications, you're on the safe side. Of course, there will be patients who may have something, but typically not. So 70 is about the magic number at the moment. But don't forget, this is the nominal number. So 32 to 40 is the nominal. So you have to sort of justify for yourself, why do I give more? Of course, if you do 160 applications, like here, everybody knows this is crazy, right? It's the same like when you use RF and you do 100 grams of force at the roof. Everybody knows this is crazy. Nobody does this. So to be honest, if you give this many applications, you can expect complications. And I have not heard of cases where they used the nominal number and had severe hemolysis. So I have not heard about this. Right? So at the moment, especially for daycare, just stay reasonable, and then it'll be fine. And if you have a patient in whom you have to do the posterior wall and whatever, maybe this patient you want to keep overnight. Okay. The last question was again. Yes. Nobody knows. Very simple. So there are now 2 systems on the market, or coming on the market. So you have the Afera system that can use RF-PF, and there's the Thermocool SDSF dual energy, so the SDSF catheter that can deliver PFA and RF. And nobody knows exactly for which region you should do which energy. Of course, when you say, I do a PVI with a single tip, which nobody wants to do anymore, I think, right? Then you can use PFA, and maybe if you want to do mitral isthmus or you want to do cavo tricuspid isthmus, then use RF because of the spasm. Yeah. So maybe if you are in the vicinity of the coronary arteries, yeah, then you want to use RF. But for the rest, I don't see a big reason why you should use RF in the left atrium otherwise. But nobody really knows, and this has to be investigated. I think also pro catheter, because I think a lattice tip catheter, like the Afera or like the Faraflex or the Omnipulse, and they're coming. All these systems have to prove for themselves when do they use PFA and when can I use RF. So, yeah.
All right. Okay. I think that we have to finish now. I would like to thank Dr. Neven for this very informative lecture. I would like again to thank company Boston for sponsorship this lecture, and in general for their support. And we can proceed to the next session. Thank you.